Thank you very much for this kind introduction and for the invitation to talk here today. So I just want to point out, this is where I work at the Leo Foundation Skin Immunology Center at the University of Copenhagen. Please come and visit. So my disclaimers are not many, but there's a clinical study that I am involved in. I will mention this a little bit, and it's hosted by Novartis. Talking about psoriasis or any immune-mediated disease, and also as a dermatologist, it's important to remember how dynamic these diseases are. So a disease like psoriasis will appear in a patient of a certain genetic background, but that is not enough. There will also be environmental triggers. May they be stress or infections or a lot of things we don't really understand very well. And at some point, there will be a trigger that will induce focal chronic skin inflammation, typically not all over the body, but in certain spots. And here you can see a picture from a patient from a recent paper from Mona Ståhle's biobank at Karolinska in Stockholm, where this patient had a very mild phenotype at onset, and 10 years after just being part of this biobank, this patient came back in a horrific state, completely untreated and a very severe phenotype. And comparing some 500 patients with plaque psoriasis, this is a very typical setup of the disease manifestations. 65% of the patients had a mild disease, some 35 had moderate to severe disease. It was very interesting to follow on the right-hand side after 10 years that up to 20% of the patients, typically patients with presenting with mild disease at the beginning of the study, had minimal disease activity defined as no psoriasis for the last 2 years. Most of the mild patients maintained the phenotype. Some of the more moderate patients had improved, and then a few patients had gone into the more severe phenotype. So we do have a very dynamic disease. But what is also very clear in the clinics is that when patients come with focal skin inflammation, and in this skin inflammation, there will be quite an intense inflammation with, in green here, inflammatory dendritic cells, in blue, inflammatory T cells. In red, we have the Langerhans cells, which are resident in the skin and stay there all the time, and they don't really expand during psoriasis. But most importantly, you can see the intense hyperproliferation of the epithelium of the epidermis. So altogether, it is a very intense tissue inflammation that is caused by several different immune cells together with stroma cells. Nevertheless, we're very successful at treating psoriasis nowadays. May it be with topical agents such as cortisone or UVB treatment or all the biologics that we have. And the patients come back, and very often we cannot tell where the patients had the disease. And I think this brings back the beauty of dermatology as a medical specialty as compared to gastroenterology or internal medicine, because we can remember, and the patients more importantly remembers where they had their disease. So when the disease comes back, it typically comes back in the same site. Sometimes it will spread to different parts of the body. Sometimes in a very inflammatory state, we also see the Koebner phenomena, where patient following physical interference. I once had a patient coming after his sons had been shooting him with a pea gun. So he had little peas on his belly. And this is a very inflammatory phenotype of psoriasis that proves to us that there's also a circulatory component of the disease. So it can be reintroduced in new places on the skin costume. So the whole concept of disease memory or localized disease scars has been very anecdotal. And for a long time, I was looking for proof for someone who had been really mapping lesions before and after resolution. It has been very difficult to find. Fixed drug eruption has been well documented in the same sites after very long times of resolution. Psoriasis, contact allergy, and vitiligo, we know they come back in the same sites. Atopic dermatitis is a little bit more of a mobile dermatosis. But I was very happy a few years back when Lars Iversen in Aarhus University published this paper where a small cohort, but still of patients, were followed very closely before and after climatotherapy. So these patients went to the Dead Sea to get just a few weeks of sunshine and salty baths, and they all resolved beautifully, as you can see in the bottom, in the middle. But when the disease came back some 12 weeks after they came back from their climatotherapy, the plaques came back in the same sites in some 60% of these patients. Small study, but still just proving the point that for some reason, patients do not have random recurrence of disease in the skin costume. Previously affected sites will be more affected. So why is this? And why, coming back to the intense immune infiltration, it has long been known that a never lesional skin in psoriasis patients that have not previously been affected by psoriasis behaves a little bit differently immunologically. They have more psoriasis-form T cells, they have more of an inflammatory phenotype. In resolved skin, the Krieger lab early on showed that there is a molecular scarring. So when sampling skin up to 12 weeks after resolution of disease, there was an overrepresentation of gene transcripts that were associated with T cell biology and also with psoriasis inflammation. And as I mentioned before, in fixed drug eruption, it has been clearly shown that T cells are retained for a long time in resolved lesions. And when we look into the skin of patients and healthy people, there is a distinct population of T cells in the epidermis that is distributed all over the body. These T cells stay for a long time. They are closely interacting with the basement membrane that separates epidermis and dermis. And on top of that, there's a lot of patrolling and resident T cells also in the dermis. As a proof of principle, Jörg Prinz in the 90s already in Munich treated patients with this is pustular psoriasis, where there's a lot of neutrophils in the skin. Depleting T cells from these patients would lead to complete disease resolution, just showing how important T cells are to maintain psoriasis in patients. So we went into the resolved skin after years of resolution, after biologic treatments with primarily anti-TNF, but also anti-IL-12/23 blockers. And what you can see here in the bottom is the resolved skin, where there are small hotspots of T cells, always closely related to Langerhans cells, as compared to the lesional skin, where there's still an intense inflammation. When we looked at the IL-17 producing capacity of T cells in healthy skin, we found some 4% of resident T cells that express IL-17 when they're stimulated. In the resolved skin, and this particular patient had been in resolution for some 4 years during TNF blocking therapies, 1/3 of the CD8 cells in epidermis was still responding with IL-17 production when activated. And of course, in the lesional, there are many, many IL-17 producing T cells. So looking at several different markers, we found a subset of T cells expressing CCR6, IL-23 receptor, and Sigma-103 in resolved lesions, very close to Langerhans cells overexpressing IL-23. So where does this bring us? We know that there's a subset of T cells in the skin, but we still didn't know if this subset of T cells would drive psoriasis inflammation, or if the setup of resident T cells could tell us anything about whether these patients would remain in remission or not. So to test this, we built a very simple assay where T cells in the skin, in skin biopsies, were activated by adding T cell agonistic antibodies, and gene expression profiles were analyzed both in epidermis and dermis. The T cell reached the targets. You can see that the T cell antibody that we used, OCT3, were co-localized with T cells in epidermis, and activating healthy lesional and resolved skin induced a number of different transcripts, where a number of transcripts were shared regardless of the origin of the skin. We call these core responses, and they're often related to interferon gamma responses we need to combat viral infections. On the other hand, psoriasiform responses were found in patients with resolved psoriasis. And interestingly, this was a tiny little study with 9 patients, but we found that if the patients had more dominant responses with IL-17 related responses, the time before relapse was shorter as compared to patients that responded more with interferon gamma related responses. So this brings us to a situation where in psoriasis, we have a T cell population that is slightly changed. The balance between interferon gamma and IL-17 producing cells are just skewed towards IL-17 production, and activating these cells will lead to psoriasiform inflammation. Now, what is missing? To me as a clinician, it's really, this is all very nice and neat and interesting tissue immunology, but we really don't know how to implement these scientific findings to clinical practice. And to me as a scientist, I am right now very interested in what keeps resident T cells alive within the skin. Why do they stay there so long term? Can we somehow exchange them to more homeostatic T cells? So one thing that comes out of this is it would be very, very tempting to try to target the resident T cells simply by eradicating them, to go from this relapsing phenotype of psoriasis to a more long-term remission. Again, coming back to the dynamic phenotype of psoriasis, I think this might be difficult treating real-time patients. But another thing that has been fascinating me for time are these patients with spontaneous resolution. Would they have a different subset of T cells? And could we somehow use knowledge from such samples to understand more about the more homeostatic environment for resident T cells? I mentioned that I am involved in a clinical trial. Yes, and coming back to Paul Lemmer's wonderful presentation on early intervention, of course, this is something that I feel we should do in dermatology as well, but it's complicated to do because the diseases often start as mild and then progress with time. But I am part of a study, as I mentioned previously, where patients with quite a severe phenotype, they have PASI more than 10, are put on anti-IL-17 treatment within a year of onset of disease. And we follow resident T cell reactivity to activation to look for a potential biomarker. Potentially this could help us long term. Finally, going from a skin phenotype to psoriasis arthritis, there's a lot of discussions right now, which I find fascinating, of psoriasis arthritis as a deep tissue Koebner. So if psoriasis arthritis would be a consequence of deep Koebner, could we somehow address circulating pathogenic TRM cells to stop new disease scars from forming? And with this, I would just like to finish with thanking again for the invitation and say that there's a whole lot of work to be done when it comes to disease memories in the skin in order to bring them to clinical practice.
Thank you very much, Liv, for this great presentation, which is open for discussion. I can't see some question in this space, the chat space or the Q&A. Maybe I could start. Do you in this concept, and we know there are some models where the primary genetic abnormality is targeting a keratinocyte express antigen. Let's take the example of the CARD14 associated psoriatic disease. So my question for you is, and where there is an enhanced Th17 response deregulated, fitting very well with what you showed with your group. So do you rule out the hypothesis that in some patients where you have a primary genetically determined abnormality, basically inhibiting the Th17 deregulated response might not work on the long run in a subset of these patients because the underlying keratinocyte abnormality remains? That's my a little bit provocative question for you.
But I think, but I think this is also what Paul Emery talked about when we are now getting, clinics for patients that have been resistant to all these cytokine-driven therapies. So it's all very good to, stop the molecular signaling between T cells. But if you still have the underlying problem, you might just switch from one pathway to another. And my problem is that we need the T cells around. I don't think it's as simple as just eradicating pathogenic T cells. We need to somehow reprogram the whole tissue. And how do we do that in a good and long-term way? Because I think with some patients, they do very well with biologics for many, many years. But we do have the other subsets and especially the mild disease. Would there be a smarter way to try to reset the tissue homeostasis there? So I agree with you. I don't think that biologics is always the answer.
Thank you, Liv. And second question for you is that let's take the clinical situation of a banal Staph aureus infection. We know that it's less frequent in patients with psoriasis, but some infection occurs, and then there is a recruitment, fortunately, of immune cells and expansion and production of a cytokine, including IL-17. Are these cells? Did you have some insights or scientific results comparing these T cells recruited towards infection sites with the lesional or resolved psoriatic skin resident Th17 cells, which are deregulated? In other words, if it had, fortunately, we are fortunate that we have these Th17 resident memory cells. When infection occurs, is there any trained immunity memory, which is a very kind of contemporary concept, because trained immunity applies for many cells, not only the adaptive immune system, but also the innate immune system. So I was wondering if you check from some Th17 cells recruited by the site of infection as a sort of an indirect comparison.
No, we're really getting into this now. So basically, for a long time, we were thinking that the perfect treatment would be some microbiota cream that would drive the right resident T cells in the skin. And how would we form that? So it's something we have been playing around with a lot in my lab, just thinking about ways to design such a trial. But I think that I'm not sure, I would rather call them contextual rather than pathogenic. So the T cells in psoriasis, even though we know some antigens that they respond to, but it's a very heterogeneous population. And I think now when we're getting into single cell and where we can really start to track the TCRs, we start to understand how heterogeneous the population are. So the IL-17 cells that are there, they might well respond to common microbiota. We just don't know.
Thank you, Liv. Thank you.